welcome to the pulmonary stress testing. So this is going to look at a couple of different things, or we'll even include the 6-minute walk on here. And so this is something that you might be doing in an acute care hospital if you do 1 day a week in the pulmonary function lab, or if you work in a pulmonary function lab, if you work pulmonary rehab, or if you work in a hospital that has cardiac stress testing. This will all come in handy, and a lot of this is pretty good just in general information as well too. So let's get going. Now remember, on the front screen here it says workload is the moving 1 kilogram of mass vertical distance against 1 millimeter force is gravity. That's what we're looking at, workload. And some of the times we're looking here at what workload do you have limitation. So one of the things that we do stress testing for is to look at either cardiac limitation, pulmonary limitation, or limitation of both. And that's what we might be trying to figure out, is what is the limitation? Is it cardiac? Is the limitation pulmonary? Is it both? And then at what level is that limitation present? And so we'll see. So other names for exercise stress test: a graded exercise stress test, exercise tolerance test, exercise stress test, or exercise electrocardiography. Obviously, I just call it's more of like an exercise stress test or graded exercise test are the ones that I've seen out there. The ones that we did the most at the hospital I worked at were called cardiac stress tests, because we were doing it specifically for heart limitations. And then we would do a scan. We would scan the patient's heart, and then we would do the exercise test. And then if they once they were done with the test, and then we would do the EKG and all that stuff, blood pressure and all that stuff, why they were on the treadmill, or why they were getting the medicine, whichever one that we were doing with them. And then they would go in and scan them again, and we can see what their level of cardiac limitation is there. And so I'm more familiar with the cardiac limitations here, but we'll get into both cardiac and pulmonary. There's a bunch of different names for it. You should be aware of some of the different names. That sounds like something I might ask you in the future. Alright, so what are some indications for an exercise stress test? So we want to see how much limitation to work the patient has. Can they do their activity, what the normal activities they're living? Can they work in a construction job? Can they work in an office? Can they do the normal things that are out there? What's their level of limitation, right? What's their level of extent of that? We can sort of see the conditioning or deconditioning of the patient. This is one of the cool things that we could see with pulmonary rehab patients, is we can see how much better conditioned they are after going through pulmonary rehab programming too. So we could actually quantify pre and post rehab and show benefits to the patient. We can also see if a patient is safe enough to do daily exercise. Can they do the Zumba? Hopefully, yes. Hopefully, Derek's Zumba. But when they're looking at, can they participate in cardiac? Can they participate in weight-bearing activities? What is safe for them? Is their heart too sick to participate? Should they do modified forms of exercise out there? Things like that. We could also look at disability, or getting them qualified for rehab, especially things like pulmonary rehab. That might be like a 6-minute walk test and things like that as well. Supplemental oxygen therapy. This is when we take the patient for a walk and see how they desaturate and what level they need for when they ambulate. So this is like a resting and an ambulation test that we're looking at for these patients. So that's something that we know, that when this patient's up and moving around, they need to go from 2 liters at rest to 4 liters up walking around. So we can see how much, or titrate how much they need. So that way we know they're not going to faint and go cyanotic and all that stuff. See if a patient experiences chest pain, so that angina. If they have that issue, obviously if it's not acute, if it's just chronic and ongoing, they're stable enough to do it. We can see if that's cardiac limitation, pulmonary limitation, but we could also see at what level it's there. Preoperative, try to see how healthy the patient is before we do like an extensive surgery out there. Sometimes surgery can take a lot out of people, depending on what surgery it is and how involved it is and how long they spend under general anesthesia. And so that's something we might have to look at, is how conditioned is this patient to go through this whole process, the recovery process after a big surgical procedure. DOE, dyspnea upon exertion. Hopefully you've seen that term before. Then when we're looking at this, some very familiar we see with people that have chronic obstructive pulmonary disease or different cardiac conditions where they get dyspneic upon exertion, right? DOE could be a cardiac, it could be pulmonary, it could be both. And so this can help us sort of tease not only who it is, but where the limitation line is on that as well. All right, so we looked at some indications. So what are some contraindications? When would we not? How about no, right? When would we not do an exercise stress test? If we have an acute change in their EKG, if we go from a sinus rhythm to a bundle branch block, we probably should not do it on them until they're declared stable. Or maybe they go from a stable rhythm to like AFib. Let's say they have a stable AFib going on. That's their baseline. And so when we go to look at their EKG, then now we have changes where they're starting to do a left axis deviation, and they're starting to throw a lot more PVCs in there, like the heart's looking sicker. Maybe we won't put extra stress on that structure that's looking like it's stressed, right? So clearly if they're getting worse and worse in their EKG rhythms, that's probably not a great idea. Now obviously we want to make sure they're stable and stuff, but if they have an acute change in their EKG, we'll stop the test. We will go ahead and maybe reschedule for a later date or something like that. If a patient has an aneurysm that's uncorrected or anything like that, remember we're putting vascular stress on the patient by making them work out. And so that could easily cause an aneurysm to be exacerbated, which is not a good idea. Uncontrolled hypertension, of course, what do you think happens with your blood pressure when you work out? It doesn't drop, I'll tell you that. So when we're looking at the blood pressure, if it's uncontrolled hypertension, we could easily cause a higher risk for more. We might have more risks than benefits by doing this procedure. This is not by any means an emergent procedure. So that's why if a patient's having acute changes or sickness going on, you don't want to do it, right? That's the short and sweet of it. So uncontrolled hypertension, if they've had a recent MI, if they have a second or third degree heart block, those are not things that you want to be putting them on a treadmill with. Just saying. If they have a DVT or an emboli, of course we want to make sure that we don't want a DVT to move around and cause a pulmonary emboli, right, when we're trying to put them on a treadmill and stuff. So obviously that if their FEV1 is less than 30% of predicted, that's very low. Does that patient at that point have the pulmonary mechanics to do a stress test? No, right? So that means they have a severe obstructive issue going on. They're in the middle of a CHF situation. Doesn't mean if they have a diagnosis of CHF, it means if their CHF is sort of uncontrolled and all that stuff. If their PaCO2 is greater than 70, that's your chronic hypercarbia patients, like your emphysema type patients. Those are the patients that they might not be able to compensate respiratory wise for an increase in metabolic rate like you would see with a stress test. And then if a PO2 is less than 45 on room air, that means that their body already has a big diffusion defect of some sort or another, something that's impairing oxygen from getting into the bloodstream. And with this, you're seeing that the patient, and when we put them under metabolic stress, when their O2-ER increases and when their A to V gradient increases, right, when we're looking at their VO2, their oxygen consumption, those will all increase with exercise. And if they already have a low ability to get oxygen to their bloodstream in the first place, we could send them into a metabolic acidosis on top of a respiratory acidosis. So we could send them into an acidosis very, very quickly. So that's something you got to be cognizant of. And that's why these are pretty much contraindications here. Relative contraindications. This is where we'll look at the benefits of risk to benefits ratio on the certain patient by patient basis. So if the patient refuses or physically unable to do it, obviously we're not going to be able to do it. So that's a relative contraindication. Mild pulmonary hypertension, usually this is not what we'd get off of a SWAN nowadays. Most, as of recording this is something we would get off of an echo. Right, we'd do an echo and see if they have pulmonary hypertension or cold pulmonale. If it's mild there, we'll consider risk versus benefits on it. We might just have to take extra precautions. Electrolyte imbalances, it won't completely pull you out. It just means that we need to make sure that you're good to go. And if you have uncontrolled diabetes or asthma, we need to get those under control, especially with things like blood sugar and the ability to breathe. When we're putting someone under stress, what do you think happens to their blood sugar? What do you think happens to their inflammatory response that you would see with asthma, right? So these are all things we have to make sure are in place, right? You want to make sure their asthma is under control, their diabetes is under control. And so these are sort of relative contraindications. We're looking at the risk versus benefit ratio in this specific patient is what we're doing. All right, so when we're doing a stress test, what kind of monitors are we looking at, or what do we need to look at on this patient? Well, heart rate's going to be one of the big things that we're going to look at, especially if you start to see the heart rate increase and their respiratory, if you start to see a sudden acute change in the respiratory rate and their heart rate. We're going to be comparing respiratory rate and heart rate quite a bit when we get to the exercise stress test, not the 6-minute walk, but exercise stress test. So we can sort of see when they hit anaerobic threshold, how early do they hit anaerobic threshold, and that's not something we'll talk about in depth here. But if you want to go into exercise stress testing, that's amazing. It's really interesting stuff, I think, anyway. I like diagnostics, but when you're looking at all that type of thing, you can actually look at athletes and see how well conditioned an athlete is. You can measure their anaerobic threshold and then have them train a certain way and then remeasure their anaerobic threshold and see if their nutrition changes or the way that they trained changed their anaerobic threshold. It's pretty interesting stuff. And there's such a good plethora of information out there on anaerobic threshold. So if you're interested, please look into that. It's pretty interesting stuff. So heart rate, ECG, of course, we're going to look for things like PVCs. If you start to see PVCs start to appear more frequently, remember that's a sign of hypoxia or hypoxemia, right? Because the heart's not getting enough oxygen, so it's starting to do abnormal things. So if you see a sudden acute rhythm change, like a bunch of PVCs starting to pop up that aren't artifact of the patient running, right? That could be a sign of hypoxia and all that bad stuff going on. So we want to see that early on, because do you want to stress the heart past the point of its functional compensation? No, right? You want to see that the heart's kicking in, and we want to see at what level. That's why we're doing a continuous EEG or EKG, sorry, not EEG, EKG throughout the whole thing, right? ST segment, we're going to keep looking at that. We want to look for injury, so we want to look for depression and elevation parts. Obviously, any changes in the ST segment from baseline, we'll probably stop the test because usually that indicates something bad is going on. Respiratory rate, like I said, this is going to be one of the big things to watch, especially if you're looking for anaerobic threshold. Pulse ox, pretty easy on that one. The big thing is just making sure that they keep that one hand stable. Watch those videos that Stacy included on their on your screen for day one there, and you'll see that they have to sort of keep that stable. Same thing with like the blood pressure. Usually they'll have to keep one arm sort of hand on the treadmill, or sometimes they just sort of have to put it up there and keep it as stable as they can so we can take a blood pressure, get a good saturation readout. ABGs, if serial ABGs are needed, then we'll put in an A-line. If you've gone to National Jewish, they put in A-lines all the time over there for exercise tests, and they're looking at serial ABGs, at what level do they go into anaerobic threshold, and look at the lactic level and all this other stuff. So that's pretty cool stuff when you get into it. Sometimes you just need to draw an ABG. That might be just a stick, which while a patient's running on a treadmill, not as easy as if they're on a bicycle or AKA cycle ergometer, right? So that's something that you'll have to play it by ear. If they want serials, then you'll probably have to put in an A-line on this patient and draw serial blood gases, which is pretty interesting stuff. Physical assessment, obviously, we need to make sure that they're not looking more pale, that they're cognizant, that they're not about to pass out, like they're able to understand and follow commands. And obviously, we'll do a modified Borg dyspnea scale. It's a beautiful question. A modified Borg dyspnea scale to sort of see where they're at, especially when we're looking at things like the 6-minute walk test. All right, so the ECG usually needs to be monitored at all times. We'll do one while they're lying down. We'll do one while they're sitting up. We'll do one baseline when they're on the treadmill. And then we'll do them continuously throughout each phase of the treadmill cycle. So there's steady state and multi-stage when we're doing the EKG or the exercise stress test. And so at each level, we'll take at 3 minutes or at 5 minutes when the level changes, we'll go ahead and do another EKG, right? We'll look at the 12 lead as it progresses through their exercise tolerance, right, through their levels. So this is something that we'll leave on them. These are special sticky pads that have to stick on their locations for the EKGs. So the big thing here is to eliminate as much artifact as you can. Usually they'll have to wear this sort of mesh shirt, so please look at that video. I think that one of those videos that she has in there shows them wearing a mesh thing to keep the leads sort of tight and from flopping around all over the place. So eliminate as much artifact as you can. You might have to shave the electrode site, and then sometimes they'll also put this, like, I want to call it degreaser, but what it does is it takes some of the oil off of the skin, so that way the pad will stay on there even when the patient starts sweating, right? So shaving, that's why I have that picture there. So shaving might be indicated in some of these patients as well, just to make sure that you eliminate all that artifact that could be going on there. Limb wires might need to be modified to the torso. In other words, your lower limb ones, instead of going on the patient's legs, they go below the belly button area. Now, if the belly button hangs below, I think you sort of get where I'm saying, but just somewhere below the belly button, but above like the hips, so above the pelvis, but below the belly button area. And so that's where we might have to put those lower limb leads, right? So that way they're not tripping over each other and causing more artifact as well. Make sure you stabilize and secure the lead wires. That's where we put that sort of mesh shirt on them, just to sort of keep everything in place from being torn off. Alright, so let's start off with the 6-minute walk test. So this one, not a lot of information in your material, in any of your books really. There's a little bit of it in Egan's, and I think some of that's on, so check your schedule. The calendar has what chapters and all that stuff. There's a little bit, and I think I put a link in there. You see the link at the bottom there, that thoracic.org. The ATS, the American Thoracic Society, is who do all the PFTs, and they also do the 6-minute walk stuff. They're the ones that are the organization that controls all that business. And so that's where I got a lot of this information. So if you're curious, that's where I got a lot of the 6-minute walk information. So click on that, and then you'll get a lot more information. So the 6-minute walk test, we tend to score low on this area of the board, so don't lose it. It's free points, right? So 6-minute walk test looks at functional capacity. I'll repeat that again because it sounds like that could be a test question. 6-minute walk test looks at functional capacity. If I ask you which of the following tests looks at functional capacity, you should pick the 6-minute walk test because it's saying how well they function just day to day, right? That's what we're looking at. So none of you should miss this. Functional capacity. Okay. We're looking at how far they can walk during a 6-minute time period. And they can stop if they want to. They can go as fast. There's no running involved. But they can go fast. They can go slow. They can take breaks. The timer just doesn't stop. And we just measure how far they've walked totally in that 6-minute time period. So it's not very specific as far as, like, is this cardiac limitation? Is this pulmonary limitation? It doesn't look at that. And that's not what it's designed to do. It's designed to look at functional capacity, right? So it's not looking at cardiac or respiratory. We just want to see how well they function, right? So this is self-paced. We're not making them huff and puff. You're not doing a Zumba class with, unfortunately. They're allowed to stop. They're allowed to take a water break. They can do that, whatever they want, as long as they get the test, as long as they're stable as long as we get it all done in there, so they can stop and rest. So we're looking at their daily activities with this one. Are you able to walk around with your dog, take your dog for walks, right? Are you able to, what's your level of impairment just day to day with your activities of daily living? So indications for a 6-minute walk, we just want to see heart-lung disease. So we want to see how well they've done to transplantation or a wedge resection or pulmonary rehab pre and post, how well they've responded to that. We can also quantify how bad their COPD is on their activities of daily living. We can look at their pulmonary hypertension with this. We can look at the heart failure, how bad is their condition on their activities of daily living. I hope that makes sense. We want to find out how bad their condition is on their activities of daily living, and this is going to be sort of the way to look at the activities of daily living. Right, so the big thing is looking at their activities of daily living, or their ability to do their activities of daily living. How bad is their COPD limiting it? How bad is their pulmonary hypertension limiting? How bad is their heart failure limiting their activities of daily living? So it's just a one-time measure of their functional status. We can always do it again down the road, like let's say pulmonary rehab. We can get them into pulmonary rehab with the 6-minute walk, and then they'll do a 6-minute walk towards the end of it and sort of show their progress, right? This can be a predictor of morbidity and mortality for some patients as well. So it can be very helpful for physicians in making a game plan for their patients. Right? What it does not do, and this is an important list to look at if you're paying attention here, it does not determine their peak oxygen uptake. So we can't see their oxygen consumption or their VO2 max. It does not diagnose what's causing their dyspnea on exertion. In other words, we don't know if it's cardiac or pulmonary or both. It's not specific to that. It does not evaluate the causal limitation. Like I said, it's not specific to cardiac, it's not specific to pulmonary. So if I were to ask you, which of the following would be least likely to be useful in diagnosing someone's exercise limitation, you would probably say the 6-minute walk test. I'm just saying. All right. This information is only complementary to exercise testing, not a replacement. Right? We're not going to replace an exercise stress test with a 6-minute walk test and say they're equivalent. Right? They're not. Improvement on the test, the people that go further after they do that second test, in other words, they change something and they have a lot better, have been shown to have a subjective improvement in dyspnea. In other words, they don't feel like they're short of breath as much in general. Pretty cool, right? When we're looking at activities of daily living, high levels of depression and things like COPD, that's a very good statistics, right? So don't overestimate that statistic. That's a very beautiful statistic when we're looking at this. Things that you need for 6-minute, you need some sort of stopwatch. Flat surface, you don't want to make them climb up and down stairs unless you're having a crummy day. I'm just joking. So flat surface with turnaround points. You usually need to know how far the turnaround is. So you need to know one lap is 50 meters, right? So down there is 50 meters and back is 50 meters. So that way you can quantify how far they went in the course of that 6 minutes. So you need to have that measured out ahead of time. A wheelchair is great because if you need to put them on oxygen, you can put them in the little oxygen holder in the back of the wheelchair. Or if they get tired, they can take a break and you could follow them with the wheelchair and they can take a break in the wheelchair. Right? Oxygen, of course. Now, does this mean they need to wear it at all times? Unless they're not wearing it at base time, they don't need to wear it at all times. Now, if they desaturate, we can put it on them and keep going, right? But we need to mark what time and how far they went obviously when we put them on oxygen. Blood pressure, this is not something that we're going to keep checking during the middle of the test. If they feel faint, if they start looking really flush, if they start looking pale, obviously those are all indications that you might want to check it again, but we'll do it before and after traditionally for a 6-minute walk test. Emergency equipment available, know where your code card is. You're putting stress on a patient that is not healthy at baseline. And so you need to be able just to know where, have your game plan for that as well. Know if this patient were to somehow collapse in code, where would be the closest source of a defibrillator? What would be the closest source of emergency equipment? So no need for continuous EKG on this one. This is not something we'll usually do with these patients. That's more for your steady state or your multi-stage testing. Pulse oximeter, I will tell you now, pretty handy to have on these patients, because then I can look at their heart rate and their sats, and if they're dropping, if I need to put on oxygen or anything like that. All right, so they can use their normal walking aid. So if they use a walker or a cane, that's perfectly fine for them to use. That's not something that we're going to take away from them and say, okay, now try to walk, right? That's not fair. That's something that they would normally use on their daily life. So make sure that they can have whatever that they would normally have. If it's okay for them to use their walker, it's okay for them to use their cane. We just want to see how far you can go in a 6-minute time period. Right. Make sure that they're well rested. So this is one of the things where we had a patient show up to our pulmonary function lab, and she had stated she walked like from the end of the parking garage, and the elevator took forever, so she walked down all the stairs. Now we're talking about a sick person, like someone that has COPD, right? She walked down the stairs, then she walked all the way to the entrance of the ER, then she walked all the way up to the PFT lab. And so do you think she was well rested by the time she showed up for the 6-minute walk? Absolutely not, right? So we spent some time talking, right? So that's something you just want to make sure they're rested. I always had them sit in the chair before the test, and this is where I would do all the questions. So I'd take them to the location in a wheelchair that we had measured out for the 6-minute walk, and then we would that's when I would do all my questioning, right? I'd be like, any swelling of her feet or ankles lately, any chest pain, right? This is where I'm asking all my boring questions, and this is just so we can get a good rest in before we go ahead and do the procedure. They are supposed to rate their baseline dyspnea and fatigue using the modified Borg scale, and I have that on another screen in here that you'll see. Then once we get everything ready to go, we got baseline vital signs and all that good stuff. We'll set the timer for 6 minutes. You'll inform them of the procedure, right? What we're looking at and how they can use whatever they need to. If they need to take a break, they can, right? And then we'll tell them we'll walk as far as we can for 6 minutes. You can slow down, you can stop, you can take a break, but the time, I won't stop my timer, right? But there's no jogging or running, right? It's just like we're at the beside of a pool, like no jogging or running. You can hasten, but you cannot jog or run. So this is a picture of the modified Borg scale. Hopefully you appreciate the picture there on the side. Some of you may, I don't know. So this is where they rate their level of dyspnea from like severe to very severe to I don't know how I'm still standing up severe. So this is sort of a modified scale that they would use to look at this. This is a great sputum bowl question. They always ask about the modified Borg scale. All right, so the graded levels of the shortness of breath using the modified Borg scale. This is done before, during, and after the test. And then we're going to make sure when we're doing this that we're being encouraging, right? So that's why I have the cheerleaders there. You want to be encouraging. You want to be in an asset-based mindset. Hey, you've made it this far, right? If you keep on going if you can, but you've made it this far, like you're in an asset-based mindset here. Sometimes it's good to sort of exaggerate the counting of the laps. Like, you've done 13 laps. Like, that's great, right? You're doing well. You have 5 minutes left, right? You're doing really good. You're halfway done. You only have 1 minute left, right? Keep up the good work. Now, I'm not trying to force them to keep going. I'm trying to encourage them not to give up on themselves, because a lot of these patients will feel embarrassed. They'll feel very very vulnerable doing this test. And you got to be an encourager. You got to let them show that that vulnerability is okay with you. Like, you're there to be an encourager. You're there to be a helper to them. So anything you can do to help them feel more comfortable in that it's okay to be vulnerable. It's okay to say I need to stop. It's okay to say I need to slow down. That's okay. And I'm just here to help you, right? So try to be positive with these patients. A lot of times it's a very vulnerable thing when they're, and a scary thing for some of these patients when they're going through this test. And no matter what, right? You're putting a patient on non-invasive ventilation. It's scary. You're covering their whole face with a mask, right? So you're there to sort of help them through that vulnerable state, whether you're doing an outpatient 6-minute walk test or you're doing an inpatient procedure like a conscious sedation or something like that. So just be aware of that, right? Those are some of the things that make you a good respiratory therapist, is being in that, hey, I know you're in a vulnerable state right now, but I'm here for you and it's okay. We're in this together, right? So if they stop, remember, you just need to record how far they've gone in that time period. So record the distance and the time they achieved in that distance if they stop before the 6 minutes is through. So let's say someone ends at 4 minutes and 58 seconds. So you stop the timer, and at 4 minutes and 58 seconds, you record they went 200 meters, right? Whatever it is. So that way they know sort of how their pace was. Once we're all done, measure their vital signs again, have them rate their level of dyspnea on the modified Borg scale. Congratulate them, get them a drink of water if they need it, right? They're going to feel tired, hopefully. Well, not hopefully, but they're going to need something to replenish themselves. So offer them a drink, give them a little relaxation before they have to trudge through the parking lot again. All right, if they need more oxygen in the test, we can give it to them, but make sure you chart it. At 3 minutes, time, and we went this 200 meters of distance, then I applied oxygen after seeing their saturation was 84%, right? Whatever it is, right? So you just need to document it. Note the oxygen device. Was it their TTO? Was it a nasal cannula? What was the baseline if they started off on 2 liters and you increased it? What did you increase it to, right? Are they on a liquid tank or a gas tank or a concentrator? This is important because each of those sort of can weigh differently when we're dragging them around for 50 meters or for 100 meters or for 300 meters, right? So those are things that they take into consideration if we're trudging around a heavy liquid tank or a gas cylinder or a concentrator. That's something that can help the pulmonologist evaluate the situation a little bit better. If the tank was pulled, carried, pushed, anything like that, right? If they have one of those ones where they sort of hook it on their shoulder like a purse, or do they have like the fanny pack thing with the concentrator, right? Those are all things that you want to just document, make sure you have on there. If the saturation decreases by about 4 to 5%, this is called an exercise desaturation. That looks like a good quiz question or a test question. Just saying. The graded test, so if they drop by 4 or 5% during the test, right? Exercise desaturation. So we've gone 4 minutes into the test and they desaturate to 85%. And they were normally at 90%. So that would be a 5% drop. This would be an exercise desaturation. So at what increment and how far before they had that level of desaturation? I hope that makes sense. Great for patients with moderately severe impairments, right? This is not, we're going to have them run up a treadmill at a high incline, right? This is going to be your moderate severe impairments patients that you're going to use this on. Pre and post-op evaluation to see if their recovery has been complete, and then we can also see how they're responding to therapeutic interventions for heart and lung disease. So a big one is going to be pulmonary rehab, of course, seeing how well they've responded to the conditioning and the education and the lifestyle changes that pulmonary rehab has done, right? Cardiac rehab, right? Whatever it is. Whew. All right. hopefully you got the 6-minute walk test down. I know I look a little evil for making you go through 6-minute walk test. Pretty straightforward, pretty basic, especially the more you do them, the more comfortable you'll get with them. But they're pretty important, especially when you're looking at your chronically obstructive pulmonary disease patients. And then where it sort of means a lot that you have good teaching skills or good coaching skills through that whole experience. Now for pulmonary exercise stress testing, and this works for cardiac stress testing as well. Like I said, where I worked, we did mostly cardiac stress testing. There's two primary ways of doing this. You can either use the treadmill, which is the most common. I'll repeat that. You can use the treadmill, which is the most common, because a lot of people are familiar with a walking motion, right? Almost everybody does it almost every day, right? Some sort of walking, right? The cycle ergometer is a fancy word for a stationary bicycle, right? It's an erg. It's measuring the amount of force or amount of strength that someone's pushing over a time period. But the treadmill is more common overall. Like I said, more people can feel better on that one. The seat's not a limitation. The cycle ergometer has some advantages as well, so let's sort of talk about the difference between the two. So the stationary bike or the cycle ergometer, same thing, and in fact I would know the alternate word for stationary bike. Just saying. Good for patients that had difficulty walking. So if someone is morbidly obese or someone that already has things like COPD and they already have issues sort of keeping straight up or a gait, the bike actually might be better for them because they can keep that sort of stability. They don't have to worry about lugging around a tank or anything like that. The big thing here is just adjusting the pedaling frequency and resistance to increase and decrease the workload. So that's like going to a spin class, right? And you have to increase the resistance or decrease the resistance. So we have to sort of change that. Sometimes they need more rhythmic pedaling, in other words, to maintain their reps per minute, right? And so sometimes they might need to use something like a metronome or something like that, just to sort of keep them going on that same rhythm. And that way they're not slowing down. When you increase the resistance, they're keeping that rhythm so that you know that you're increasing that workload that you're making them do. The other advantage here is the workload's independent of the weight of the patient. So if someone is morbidly obese, they won't have to worry about all that weight on their knees or their ankles or anything like that. Or let's say they're post-op hip surgery or knee surgery or something like that from a year ago, right? So this is going to be a much better option, having them on the stationary bike or the cycle ergometer compared to the treadmill. The big disadvantage that I experienced with this one, the seat can be uncomfortable for some people, and that's something that can actually limit quite a bit of patients, including your morbidly obese patients as well. So sometimes that seat is a deal breaker for them. The treadmill, like I said, this is the most common. Usually the more popular version. I am preferential to the bicycle, but the treadmill is more common. A lot of people pick that one, and you'll see it most every place out there. Usually we're going to adjust the speed and the grade, or how much vertical grade is on there when we're doing the treadmill. And so there's this whole formula, the belt length times the cycles per minute equals the speed. That formula I had to calculate on the CPFT and the RPFT exam. So it's not something that's not out there. It's something that we had to do to calibrate the machine or make sure the machine's in calibration. So that could easily be a equipment question on your board, so just pay attention to that. They're not supposed to lean or hold on to the treadmill, right? That's taking weight and workload off of themselves and putting it onto the treadmill, so no touching it unless we tell them to. Like if we need to have them hold their arms still for a blood gas or hold their arms still for a blood pressure check, then obviously that might be when we might have them hold on to a handle or something like that. Remind them not to talk unless needed. Beautiful. Patient's body weight is a factor when they're using a treadmill, so it can cause patients that do have obesity issues, or patients that do have knee issues or ankle issues, sorry, hip issues, anything like that, that weight bearing could be a factor with a treadmill compared to a bicycle. Walking or running is very familiar to patients, and that's one of the reasons why it is more popular for a lot of them out there. All right, so we have them on either the bicycle or the treadmill. What are some methods or procedures that we use? And this one's the modified Bruce protocol. That's why I have that picture there. When we're using the modified Bruce protocol, that means we're changing the level and the speed of the treadmill, or the level and the speed of the pedaling, right? We're increasing the resistance and the rate of pedaling. That's called the Bruce protocol, and the Bruce protocol is usually every 3 to 5 minutes. We'll change, sorry, minutes. I'm thinking millimeters of mercury. 3 to 5 minutes. Pay no attention to that last area. We'll change that, and that's called the modified Bruce protocol. It's one of the more popular things out there, and I could easily ask you about a multi-stage modified Bruce and how often it changes, right? That's what you're looking at there. So steady state means we're going to be at one stage for most of the time period. The multi-stage means we're going to keep ramping up the level of intensity. So let's talk about the difference between the two. So with a steady state, we're just going to go for about 5 to 8 minutes, and this is sub-maximal effort, right? Or not effort, sub-maximal level. In other words, we're not going to go to 90% of their predicted maximum workload. So we're about 50 to 75% of their maximum workload. And this is calculated, and you will have to do this calculation. 220 minus their age in years on Earth. Just saying. No using that Mars. Anyway. So 220 minus your age in years will give you your maximum heart rate. So you could do this on yourself right now. Right? So if you're 20 years old, so 220 minus 20 would be 200, and that would be your 100% target heart rate for maximal effort. So 75% of that, and that would be 50 to 75% of that, and then you would know that you're in the right zone. So once you get to 50 and 75%, then we're going to keep them there for a little while and look at what happens on their monitors, right? Once you hit that target range, once you hit 50%, so if your targeted maximum heart rate was 200, once you hit 100, which is 50% of your maximum workload, that's when we start the timer for this 5 to 8 minutes. Hopefully that makes sense. If your heart rate is unchanged for a minute at any given workload, then you have achieved a steady state. In other words, your body's acclimatized, your body's adapted for that level. Right? When we're doing this whole steady state, we know we make sure that we're at that steady state. Measurements are made as far as like VO2 or blood gases or EKGs. All those are done during the last 2 minutes of the test. So we want to keep them there, and then during the last 1 to 2 minutes of the test, that's when we're going to grab all of our EKGs, blood pressure, vital signs, pulse ox, you name it, right? That's where we're going to grab it. And so this is just looking at under a constant metabolic demand, how does your heart and your lungs function? Just a constant metabolic demand. So we're not looking at activities of daily living, we're looking at under a constant level of demand. So this would be a little bit more specific to cardiopulmonary in this scenario. So with an unchanged heart rate, there's the assumption that the oxygen consumption and ventilation are constant. So you can use either a treadmill or cycle ergometer for this, right? It doesn't matter which one you use. You can use one or the other. You're looking at therapeutic interventions or drugs on the ability to exercise. So will they do better with SABAs, LABAs, so on and so forth? Will they do better overall? Multi-stage, and this is where the Bruce protocol comes into play. That's why I have that picture there. It's also known as multi-stage or incremental testing. Obviously, we're going to change a lot of things. This one's going to look at increasing the workload, right? That's the key word, on various variables. So we're going to look at more information. We're going to get a lot more information from doing more, of course. So we're going to look at maximum oxygen, maximum ventilation, max heart rate, symptoms, limitations, right? So if they start to see cardiac symptoms, like let's say they start to develop a J point or they start to see ST changes, who's to blame, the lungs or the heart? The heart, right? If we start to see shortness of breath, coughing, dyspnea, so on and so forth, desaturation, who's to blame? The heart or the lungs? The lungs. So we can actually start to quantify or see who's to blame for our limitation here. This one, and you notice it's bold and underlined, which usually means Derek thinks it's an important thing to remember, determines the maximum tolerable workload. Multi-stage testing determines the maximum tolerable workload. Multi-stage testing determines the maximum tolerable workload, right? Which of the following determines the maximum tolerable workload? 6-minute walk test, steady state, or incremental? Incremental, right? Maximum tolerable workload. Progressive multi-stage, you're going to increase in intervals. They're going to be pretty short. Like I said, usually about 3 to 5 minutes. Monitor, you're looking at their heart rate, their respiratory rate, SAT, blood pressure, EKG. Sometimes you're also looking at other factors as well, but those are the bases. So progressive multi-stage we can do with either treadmill or stationary bike. Right, either or. It can be modified with steps or a 6-minute walk test. In other words, we can modify it for certain patients. It's more an exception than the rule. One of the things that we're looking at is their workload, and that's going to be in watts, right? And then we're going to use an increase of watts of at least 15 watts per minute. That's how we can do it with either the bicycle, the stationary bike, or the treadmill. It's hard to do that with a 6-minute walk test or to make them go up and down steps to do that. But you're looking at a quantified change in their workload. We're not just going to randomly put them on a ramp of 12 in 9 miles an hour, right? We're actually doing it at a known interval or a known level workload, and that's where that comes into play. Less than 50 watts is a low workload, right? It's a light, steady walk, right? If we're doing a medium load, that's anywhere between 50 and 100 watts. Anything greater than 100 watts is what's considered a high workload on a patient. So at what level is their impairment? Low, medium, or high? If we get them above 200 watts, this is too high for testing, and you've just done something crazy. Don't do that to your patient. So try to keep them under 200 if you can, unless you had a crummy day. I'm just joking. That's a little group fitness instructor joke there. So when you're looking at this, try to keep them under 200 watts. And like I said, you want to notice, do they get PVCs start to develop at 60 watts? Then you know that their medium workload is their limitation, and it's a cardiac limitation, right? They start to desaturate and it's at 90 watts. We know that's at a medium workload level. And we know it's a pulmonary limitation as long as the EKG and all that stuff, blood pressure, are unchanged. So hopefully this is starting to make a little bit of sense to you as far as that goes. So that way we can quantify what's their impairment, who's to blame, right? And then at what level is their impairment, low, medium, or high workloads. All right, boring screen, I love it because all these sciencey things like VO2. When we're looking at workload, how much energy is generated during the exercise test? And we're looking at KPMs, and so KPMs per minute is obviously how much power the patient's using. So we're looking at watts, or 1 watt is 6 KPMs per minute. So that's one of the ways that we're looking at how much energy they're using for the test, right? And when we're looking at their numbers, we're not usually looking at these. Now these are great to look at for how much energy they were exerting, but we want to see what happened to their oxygen consumption, their VO2, right? How much is their body consuming? Heart rate should increase with an increase in consumption, okay? So if you're consuming oxygen at, let's just say, a rate at 200 mLs of O2 per minute, which is normal, right? That's your normal baseline oxygen consumption. And so, and your heart rate is at 60, okay? So let's say you're standing up in your living room right now, your heart rate's at 60, and you're consuming 200 mLs of oxygen. Now I'm going to make you run up and down stairs, or I'm going to make you run to the kitchen and back, right? Your oxygen consumption should increase, right? Because now you're using higher metabolic rate, which means you're consuming more oxygen, and therefore your heart rate should also increase, right? To get you more oxygen to those areas that are higher consumers. So that's one of the things that we're looking at. These should increase linearly with an increased consumption. So if we see your VO2 increase and your heart rate doesn't change, something bad is going on where your heart is not compensating. Just saying. Okay, hopefully this is starting to make sense with how we're looking at cardiac versus pulmonary limitation. If we see a sudden acute change in someone's respiratory rate and they're at a steady state, then that might be when they hit anaerobic threshold, and now they're producing more CO2 or lactic acid, and now they need to breathe faster to get rid of more acid to help control their acid-base balance. So if I see a sudden acute change in someone's respiratory rate and they're at a steady state level, then I know it's anaerobic threshold, right? So hopefully some of this is coming together a little bit. So when we're looking at this, we can actually look at normals to determine how much energy they're using, and we can look at their VO2, their oxygen consumption. And this is when we can look at how much energy they need to expend at any given workload overall. So this is a stress test. Now this patient over here is wearing a mask that looks at VO2, it looks at oxygen consumption. So it knows how much oxygen she's breathing in, and it looks at how much oxygen she's breathing out. So it's comparing those two. So then we know what her consumption is. Hey, what's missing? Well, the difference between what she's breathing in and what's breathing out is what's missing. Therefore, that's her VO2. Pretty cool. So gas analysis is where we have them wear this mask. This is what you see in all the Gatorade commercials, right? You see them all with that mask on the treadmill or on the bicycle going like crazy. That's exactly what you're looking at. They're looking at the VO2 or oxygen consumption, their VO2 max. When we're looking at this, we're looking at EKGs. Obviously, you can see the EKG stickers over here. Pulse, obviously, that will be off the EKG. Blood pressure, this will be at each increment that we change. Ventilation, that's what we're going to be looking at with the mask, of course. At the end of each stage, we're going to collect all the gas information and record it to that stage. So gas analysis, like I said, this is that fancy mask that these guys wear. We're going to look at how much volume, the temperature, what time we did this, all this good stuff. So like I said, how do we know what their oxygen consumption is? Well, we know what they're inhaling, their FiO2 or FeO2. FiO2, and then we compare it to what they're exhaling, FeO2. So the difference between what they're doing is their consumption. The difference between the two is consumption, right? So let's say they're breathing in 21%, and they're exhaling, let's just say it's 18%, right? So the difference there is what they're consuming, right? So that's the only thing that we're looking at there, right? That's only a 3% difference. It's supposed to be 3. Now we do it towards the end of one of the later stages. They're breathing in room air, and now they're breathing out 16, right? That's a bigger difference. Therefore, their oxygen consumption increased. That's ultimately the concept of what we're looking at. That's not exactly what it's doing, but that's the concept of what we're looking at. How much consumption does this patient have? We can also mix CO2 gas, how much CO2 they're producing. That CO2 they're producing, if we see a sudden acute change, so let's say their CO2 is at 40, now it's at 50, that sudden acute change there is when they hit anaerobic threshold. They went anaerobic, and therefore they started producing more CO2. Hopefully this makes sense. So we can see how well conditioned the athlete or that individual is. So pretty cool stuff, I think. Also, if they hit anaerobic threshold early on, that could be a sign of pulmonary limitation as well. So this is all, I think, super interesting stuff. So we can calculate a bunch of stuff from this. Of course, I know you guys all love calculations. Minute ventilation, their oxygen consumption, which is their VO2, VCO2, their volumetric CO2 production, the respiratory exchange ratio. Oh, I love this stuff. Especially if there's a dead space process going on, you'll be able to catch it. Love it. Much, much more we can calculate off of this as well. All right, so sometimes we'll correlate this, and this guy's also wearing the mask, right? So we're metabolics. We can also look at ABG or serial blood gases. I talked about this before. We might have to put in an A line in place. That A line will help us look at the lactic levels for each different area of each different stage that we're changing. It also helps us look at the pH and the PO2 and oxygen consumption a lot better, right? If I can know what your PaO2 is, then I could calculate your CCO2, right? Not your CCO2, your CaO2, and I can look at your DO2. I can look at your O2ER, right? I can look at all these things to sort of see exactly where your problem is and quantify it much more scientifically than just guessing. So hopefully you see this is nerdy, but really cool nerdy stuff. Hopefully. That's my what I'm hoping you get out of this is there's lots of really good benefits to this, and the more you do it, the easier all this stuff becomes. I know with going through it like this without having seen it, probably not an easy way to do it. So with blood gas analysis, so with ABG, so gas with blood gas analysis, you're doing the same procedure, you're not doing anything different. ABG is done, should say done, at the same time of gas analysis. So in other words, we're pulling all the information from the gas at the same time we're drawing off the A line down here, right? So we're doing those simultaneously. Artline is a great thing to do in these patients, especially when they're running around and all that stuff. We can just pull off the A line and then let them keep going instead of just stabbing them with a needle every time. And this one looks at physiologic dead space. If it's increasing or decreasing, that would show limitation, as well as alveolar minute ventilation. Usually it's not an alveolar tidal volume, but alveolar minute ventilation to look at the effectiveness of the breathing. Their VDVT, so dead space to tidal volume ratio. Big thing here, even ventilators do VDVTs now, which is amazing. Amazing tool for you as a critical care therapist as well. So you should understand the importance of looking at someone's VDVT, their dead space to tidal volume ratio. How effective is that tidal volume breath? And we can see if there's pulmonary limitations, their VDVT will increase, which means there's more dead space. In other words, we have ventilation without perfusion, so that could easily be a cardiac limitation or perfusion issue to their issue if we see the dead space increasing. If we see the dead space decreasing, it might be a ventilation issue, because then it would be a shunt-like situation. A shunt means, once again, back with pulmonary MP, a shunt means you have perfusion without ventilation, right? So this would be a shunt-like process. That would mean a pulmonary condition, right? So if you see the VDVT increasing, it might be cardiac. If you see decreasing, it might be pulmonary. Hopefully you see how amazing this is. We can also look at their cardiac output using the Fick method as well. Obviously, we're not going to drop a swan in these patients. Anaerobic threshold, I love this stuff. Ventilatory threshold is another name for this. This is something that your board exams might ask you about, so I just keep a keen ear towards the ground on this type of thing. And this is where we're looking at oxygen consumption, where they start to go into anaerobic metabolism, where they go from aerobic metabolism to anaerobic. In other words, their blood at lactate level here will increase as they're starting to develop a metabolic acidosis. They're consuming more oxygen than what's getting to their tissues. Hopefully that makes sense. One of the big key things that you'll see here, a sudden increase in the respiratory rate is a sign of reaching anaerobic threshold. In other words, they go from breathing at 35 times per minute to now breathing at 40 times per minute, just like that. And that's a sign that they've reached anaerobic threshold. They're now in a metabolic acidosis. Now their body's trying to ventilate to blow that off to correct that. Your VCO2 in this situation, your CO2 level, your oxygen volumetric CO2 level will increase above your oxygen consumption. So you're producing more CO2 than what you're getting in oxygen. So in other words, you're withdrawing more from your bank account than what you're depositing. Right? CO2 would be your withdrawal. Oxygen would be your savings account. Right? You're withdrawing more from your savings account than what's being replenished into your savings account. So when anaerobic metabolism is attained, their pH will go into an acidosis. They'll develop lactic acid, which is something we can run off the blood gas. And then the heart rate should remain stable. So you see that sudden acute change in the respiratory rate, that's a sign they might have reached anaerobic threshold, right? That's when you draw your blood gas if they're doing the whole blood gas situation. And you can see at what point where they hit the anaerobic threshold, then you can quantify that, make changes, and then redo the test at a later date and sort of see if they hit anaerobic threshold earlier or later. Hopefully later if they've done better conditioning. Right, O2 max is something you might see out there as well. This is where work continues to increase, but the consumption does not. Not something that you're going to calculate or see a lot, but just something you should be aware of. So anaerobic threshold, when we're looking at this is something that we can look at cardiac performance. Cardiac performance. Cardiac performance. This looks at cardiac performance. So if we're really thinking this is more of a cardiac issue, they might want to check it out. Obviously, we're doing 12 leads, checking blood pressure, all that stuff that looks at cardiac function, especially if we're doing nuclear tests with it as well, where we'll scan them pre and post, but they might want to try to go anaerobic with it as well. In healthy subjects, you should see about 60% of their VO2 max is where they'll hit it. If you have heart disease, you're going to hit it much earlier. 40% of your VO2 max. So at what point can you not supply your tissues with enough oxygen? And usually the limiting factor with supplying your tissues enough oxygen is going to be your pump, right? It's going to be how well that left ventricle does at pumping out all that stuff. And if the left ventricle isn't doing well and you only get to 40% of your performance there and you hit your anaerobic threshold, that's a sign of cardiac, right? Cardiac performance. And that's what they're looking at here. So if you have pulmonary condition on top of this, let's say you have COPD with congestive heart failure, which 50% of patients out there that have COPD have congestive heart failure, and vice versa. 50% of your CHF patients also have COPD, right? So patients with significant pulmonary disease may not exercise at workloads enough to reach anaerobic thresholds. In other words, if your lungs were the problem, you wouldn't be able to get to anaerobic threshold. Right? Does that make sense? Right? You're not going to be able to have enough oxygen to get to anaerobic threshold. You're not going to be able to have enough ventilatory reserve to get to anaerobic threshold. And that's one of the reasons why this is looking more at cardiac performance than respiratory performance here. So that's why you might see this obviously more in your cardiac patients. Okay, cardiovascular measurements. So usually we're obviously going to get an EKG before. Usually we have one while they're lying down, while they're sitting up. And then standing on the treadmill, right? Usually each interval, right? At the end of each 3 to 5 minute interval, we'll get one, or if we see a sudden acute change, we'll get one. The EKG, usually we're looking at the ST, elevations and depressions. It's pretty important things to be looking at there, right? Hopefully you understand that by now. Predicting the heart rate, obviously we'll look at that. There, you can either do 220 minus their age, or you could do this one, 210, and then take 65% of their age, subtract 65% of their age from that. It's a whole, both of those are pretty much the same, but 220 minus the age, they had me calculate this on the board exams, just so you're aware. So this is something that you might see down the road on a board exam as well. Remember, your heart rate should increase linearly with the increase in consumption. So that's why we're looking at cardiac issues. If your heart rate increases and your stroke volume increases, your cardiac output should also increase. So this is a sign your heart's compensating appropriately, right? And so one of the things that we can look at their cardiac output is use the Fick equation, where you take their A to B gradient times 10, right? And then that's under their oxygen consumption. We can see roughly what their cardiac output is. If their cardiac output decreased from level 2 to level 3, if it decreased in between the two here, right, then we know that that's where they had cardiac limitation. That's where their cardiac output started to drop. If someone's cardiac output starting to drop while they're working out, bad sign. All right, so deconditioned patients, obviously their stroke volume is going to be very limited. So heart rate is the sole determinant of increasing cardiac output with exercise. So your heart rate should increase with an increase in workload, right? So that's something that should happen every time you increase the level of intensity, increase the speed of the treadmill, and then increase the height of the treadmill. You should see the heart rate increase with that increased workload. That should be a linear relationship. When you don't see that relationship, that's a sign there's something wrong. So if you see a decreased heart rate, so you have a patient on a treadmill, right? And you see that the heart rate's at 136, okay? And then you increase the speed and the height of the treadmill, and now you see the heart rate drop to 122. And we've just done this change. That's a sign that the heart rate decreased, and this can indicate that they're going through a cardiac insult right now. Like they could have an ischemia or heart block, right? What would you do? Would you keep them running on this treadmill if you're starting to see an ischemia or heart block? No. All right, we're not looking at job security here. We're just no, like stop the test, right? So that's something that you want to be aware of. Now remember, a patient could have beta blockers or a history of a cardiac ablation. If they had anything like that, that's something you should know ahead of time. But if you see a decreased heart rate and they don't have a history of an ablation or ablation, I think it's with an A. I'll have to look that up. Or if they're not on beta blockers, then this is a sign something bad is going on here, right? Hopefully you all see that. If their heart rate increases with increased EKGs, this might be associated with more CAD or cardiomyopathy, which is what you're usually going to find. So you start to see like a bundle branch or more PVCs, you start to see something weird going on. It might be a coronary artery disease or a cardiomyopathy, which, like I said, is most typically what you'll see. It's not too common that you'll see this situation down here in the bottom right hand corner where they start to do that ischemia heart block situation. All right, so let's talk a little bit basics about EKG changes that you might see. With exercise, depression may indicate ischemia. So if you're doing an exercise test, and if I give you an EKG, sounds like I will. If I give you an EKG, and I know you all went to an SVT right now. If I give you an EKG and you see a ST depress, right? Then you should say that sounds like ischemia, right? Depression down here. For this right one, you see how it goes below that baseline, right? That's that depression that's going on there, and that means there's ischemia going on with the heart. What would you do? Would you keep this patient running hard and working hard when their heart's going through ischemia? I hope you said no to that. PVCs, very, very common to see PVCs. PVCs, especially the more frequent you see them, are associated with ischemia in this situation. Now, traditionally in respiratory practice, if you start to see PVCs, it's a sign of hypoxemia or there's an acidosis going on. And so PVCs are a very bad sign, especially when a bunch of them decide to show up together. They're bad in groups. Don't let them group up. Because when they start to group up, they usually mean that they're going to go into a lethal arrhythmia. So PVCs, if you have one here or there, it's not the worst thing. I mean, you probably had one this hour with a cough or a sneeze or something. But when you see them grouping up, not good, right? Do not like those. So if you see more than 10 per minute, it actually can indicate like a mitral valve prolapse. So obviously that's some cardiac limitation as well. So, you know, lots of PVCs in a row, not a good thing. If you see couplets, you do not want PVCs to couple together, because usually that means you're about to go. It's like seeing clouds of a tornado on the horizon, right? It's going to precede a VTAC or a VFib. Neither of those are great. So please, if you can avoid those, that would be nice. So if you start to see them together, make sure the other person in the room is aware of such situation. And usually that's an indication to stop or make sure all your leads are on correctly. Numerous PVCs indicates the stopping of the test, right? This sounds exactly like something I would ask you, right? I'll give you a scenario, I'll give you the EKG, and you see a lot of PVCs together. What would you say? The patient's unstable? You would say to stop the test. Please say stop the test. Please say stop the test. Remember, depression is ischemia. Ooh, so what does this indicate? I just repeated it. Last slide. What do you see? So this is a normal one. This is your ST depression. This indicates ischemia. Would you continue the test? Yes or no? You answer me. Alright, so ischemia means there's reduced blood flow to the tissue. Not good because that means tissue is starting to die if you have reduced blood flow to it. Obviously that's not good. If you have an injury, often from ischemia, that's where ultimately they can go into cardiac injury. Necrosis, or death of the tissue, is the end result, and this is where they go into a myocardial infarction, right? Because now part of the heart muscle, that myocardium is starting to die because it's going through less perfusion. Yeah, that's not good. So ischemia will show up as a depressed or an inverted T wave. That was that previous slide that we just looked at. In injury, if they're going under cardiac injury, so that's where we're looking at MIs, you might see that elevated ST segment, right? That's a sign that injury is occurring in the situation. According to NBRC Hospital, okay, this is where I'm getting this, infarction. If they have an infarction, they might see this in the significant Q waves, and I have some examples upcoming here of this. A Q wave half the height of the R waves are considered significant. So, or you could do like one small square, right? That's going to be significant. So this is the example of the significant Q waves. Here's the QRS complex, and we're looking at a really wide or a really deep QRS complex. So 0.03 or wider. So if it's wide or deep, it's not good, right? You do not want to see a deep Q wave of the QRS complex, right? So according to NBRC Hospital, that's a sign of infarction, right? Whew. Talking a little fast here. All right. Most commonly, non-significant Q wave, commonly found in leads 1, AVL, and then your ventricular leads 6, where you're looking at that. All right. What do I do, right? If I see a lot of PVCs, normal sinus rhythm with occasional PVCs, we're going to give them oxygen, right? Obviously, because that's a sign of low oxygen levels. And then we'll continue the test depending on how they do. If you start to see a patient go into VTAC, well, if you see a VTAC and the patient looks pale and they're like collapsing on the treadmill, that's a sign you probably want to do some electrical therapy. Synchronized or non-synchronized VTAC? Alright, you should know that. And then it sounds like I might ask you synchronized or not synchronized. Do you want to continue the test at this point? Keep them on the treadmill? Hopefully you said no to that. VFib. Obviously this is an indication for electrical therapy. Synchronized or unsynchronized? You tell me. Should you continue the test if someone goes into ventricular fibrillation? I hope you said no to that. Motion artifact. If it looks like VFib and the patient's talking to you somewhat, just like short of breath, and they look colorful, all that stuff, just check your lead placements, right? Just like doing the vest therapy, the vibration vest therapy on patients, it looks like VTAC, and so that's why I always would call the EKG people in the EKG room, be like, hey, I'm going to start vest therapy on this patient in this room, just so you know if it looks like VTAC for a couple minutes here, that's me. Right, so that way, yeah, no one comes running into the room and be like, what's going on? Alright, ooh, what do you guys see here? I love application. Looks like Derek wants you to look at EKG rhythms. What do you see here? Hopefully you're looking at these and you're like, in 2 or more leads, I can see elevations. Is that injury? Is that ischemia? Alright, you tell me. I love this part. Uh-oh. we have another EKG. What does this indicate, and what would you do about it? All right. Another application. You're doing a treadmill test on this patient. You see this EKG. What would this indicate, and what would you do about it? On this one, I'll give you a hint. These look pretty significant. Just saying. All right, you're doing an exercise stress test. This is something that you see. Of course, you see at least 2 of them here. What does this indicate? And what would you do about it? And I will tell you, this person is stable. Is there a therapeutic intervention that you might suggest? Oh heavens. All right. What you are doing an exercise stress test, the patient becomes pale, altered, you start to see this rhythm going on. What does this indicate, and what would you do about it? I will add to this, synchronized or unsynchronized, and would you continue the test? Oh heavens. You are doing an exercise stress test, and you see this rhythm. What does it indicate? What would you do about it? And I will tell you, this patient is pale, not responsive. Their pulse is very thready and weak, if present at all. Synchronized or unsynchronized. Continue the test. Now let's do the same thing. You're looking at this, and then the patient's, just red, but sweating, working out hard, able to respond. You see this rhythm. What would you do? What does that indicate that's going on? And what would you secure? What would you look at? I love this. Oh heavens. Oh heavens. All right, what does this indicate? You're looking at this. Take some time, pause the video. This is meant for you guys to work hard and start to identify these things, because you will have to do this. I am not making this up. What does this indicate, and what would you do about it? Alright, so hopefully that was fun for you. I know it was for me. Alright, blood pressure. So systolic blood pressure during normal exercise conditions may increase up to 250, right? So it could easily jump up. That can be normal adjustment for a healthy person. Diastolic pressure should only go up by 10 to 15 millimeters of mercury. That's it. Systolic should be the one that takes the skyrocket. Diastolic should not be the one that skyrockets. So non-invasive blood pressure is fine. Make sure that you take a baseline before you start the test. Otherwise, the nurse practitioner is going to be very unhappy with that situation if you don't have a baseline beforehand. Sounds like Derek made that mistake before. All right, arterial line can be more accurate at higher workloads, of course. Patient won't have to hold their arm still while they're trying to run up a very steep incline that's going very fast. So that's where that could be helpful, especially if you're doing multiple blood gas analysis during the whole thing. If their systolic blood pressure does not rise, notice this is bold and underlined, so it looks like I want you to look at this one. If the systolic pressure does not increase, or let's say it not only doesn't increase, but actually starts dropping. So let's say we're at 155 over 100. Okay, so we're at 155 over 100, and then we increase the rise and the speed of the treadmill, right? We increase the grade and the speed of the treadmill, and now we're at 110 over, let's just say 90. This change here, not good. That's not something that you want to see here, and that's a sign that you need to terminate the test and inform the physician. This indicates that your cardiac output is not increasing appropriately with that change. In other words, your cardiac output has gone downhill. In other words, you might be going into cardiac failure. So if you see that dramatic change in their systolic blood pressure where you increase everything and you see their blood pressure drop, not good. Normal responses, we talked about that with the blood pressure change. You want to see it increase with increased levels. Obviously not the diastolic too much. Heart rate increases linearly with increased workload. So high rates without any EKG changes are common in patients with poor conditioning. In other words, you just barely increase it and their heart rate can jump up really high. That's normal if someone's poorly conditioned, right? If you see depression changes greater than 1 millimeter for at least 0.08 seconds or longer, this is a sign that they're probably going into ischemia, right? So obviously I need you guys to become familiar with the EKG strips because I will ask you about that on your test. Exactly what I was doing earlier. What is this? What does it indicate? What would you do? Synchronized or unsynchronized? So on and so forth. PVCs are more commonly associated with ischemia, so usually you'll see those first. Especially more than 10 per minute, you'll start to see that before usually you'll see the ST segments. But, you know, individuals decide they want to pronounce themselves in different ways. You know how that goes. Blood pressure increasing from the 120s to 200 to 250 systolic is normal. 80, then it can go up to about 95 diastolic is very, very common to see as well. All these should increase with workload increases down there. Rate, tidal volume, minute ventilation, that should be a normal response. So CO2 production and consumption will rise together as a workload. That makes sense. You're going to produce more carbonic acid, right, CO2, and you're going to consume more oxygen the more workload you do. Usually this is something that we'll look at. The respiratory exchange ratio is VO2 and VCO2. We're just comparing those two together. That's your respiratory exchange ratio. Hopefully you remember that from back in pulmonary MP. I know none of you do, but it was there. We did cover it. However, I'm sure you all keep that ratio in mind all the time. pH might rise at the beginning. Initially, when people are doing these tests, they might go into the hyperventilation, just like in disease class, which I'm sure all of you remember. Initially, that hyperventilation hits, and then it will fall once they hit anaerobic threshold. So that's another way of seeing when they go into anaerobic threshold, is if when their pH went from being alkalotic to now being normal or acidotic, right? Dead space, VDVT will decrease secondary to increased pulmonary perfusion, right? So that's something that we're looking at. There's the alveolar capillary membrane. Here's deoxygenated blood. So what this is saying is our dead space to tidal volume will decrease the more we pump blood. So my right side of the heart, I'll draw a blue right side of the heart, and then I'll draw an oxygenated red left side of the heart. Then we'll assume ventilation and oxygenation have occurred. All right, so when we're looking at this, I'm going to use purple here. Blood flowing into the heart and then sent to the lungs. When I increase my workload, I'm supposed to increase how much perfusion, right? My heart rate's supposed to increase. My heart's supposed to squeeze stronger. So I'm going to send a lot more perfusion to the lungs. Remember, the definition of dead space is, come on, ventilation without perfusion. Ventilation without perfusion, right? If you're not perfusing, you're dead. So if we increase perfusion, our dead space should decrease. Right? If we're increasing perfusion, if we're increasing blood flow to the lungs, our dead space value, if we're looking at the respiratory stuff, if we have that mask on them, should actually start to decrease because we're sending more blood to the lungs. Our VDVT will decrease. So that's why, let's say you had a patient in critical care on the ICU, in the ICU, on a ventilator, and you give them a liter of fluid bolus. Let's say that they're dry. Let's say that their output exceeds their input and they're dry and they're compressible on their vena cava, right? So you give a patient a liter of fluid, of just normal saline, let's just say, and you give them a liter of fluid. What happens to the amount of perfusion going through the lungs? Did it increase or decrease? Well, as long as their heart's functioning appropriately, it increased, and therefore you should see a decrease in their VDVT because now we have increased perfusion. I hope this makes sense. So with exercise stress testing, you should see a decrease in VDVT because of the increased cardiac function, because of the increased perfusion. If there's an increase in pulmonary artery pressure, this is usually an indication of a ventilatory limitation. Because what happens with the pulmonary conditions, remember disease class, we talked about pulmonary artery pressure and pulmonary vascular resistance. All those would be increased in pulmonary conditions because there's hypoxic pulmonary vasoconstriction. So your capillaries get very narrow and constricted when you have low oxygen getting to your lungs. So that's hypoxic pulmonary constriction, right? And then that's going to cause a backup of pressure, and a backup of pressure, so your pulmonary artery pressure is going to increase, right? So increased in pulmonary artery pressure is usually a sign of a pulmonary condition. I hope that makes sense. So if we have a swan in place, or if we had a central line in place, and we're looking at CVP starting to rise, that could be a sign that this patient has respiratory limitations to workload, not cardiac limitations. Now, at any point, I want to make a point of this because this looks like a good test question. At any point, their saturation is less than 85%. Do you want to continue the test? Just say no. All right, ventilatory or cardiac limitations. This is sort of summarizing here. We're in the summarizing area. Ventilatory limitations at low, if they start to drop their saturations, they develop respiratory acidosis on their blood gas, increased pulmonary artery pressures, increased respiratory exchange ratio would be a pulmonary limitation. If their EKG shows a normal ECG, so normal tracing and heart rate, right? Those are what we'd be looking at, or they reach their MVV, which is the FEV 1 times 35. I would remember this equation. Sounds like I could ask you about that one again as well. Those are signs that we might reach limitation, right? So these are all signs of ventilatory limitation, right? If we reach their MVV, then that's a sign that they hit their ventilatory limitation. That's their maximum voluntary ventilation. That's as fast and as deep as they can breathe. So that's a ventilatory limitation. If we don't see any EKG changes, if we don't see any weird heart issues going on, like blood pressure or EKG things, and it's going to be a pulmonary limitation to exercise, right? Increased pulmonary artery pressure, that's a sign of pulmonary disease, right? So all these are signs that it's your lungs to blame for your limitation to exercise. You should be aware of the list of lungs versus heart here. Cardiac limitations, right? If we see a lot of EKG changes and the respiratory rate doesn't change much or anything like that, we see a lot of weird arrhythmias, anything like that going on, the blood pressure issues, right? Anything like that, that's a sign this is cardiac, especially if we have less than 70% of their MVV, then these are all signs it's your heart. So the limitation to exercise, or their limitation overall, is cardiogenic. All right, so what determines terminating the test? This looks like an important slide. If they start to have ST depressant, of course, this means ischemia and bad things. Inverted T waves, Q waves, VTAC, of course. Sustained SVT, oh my heavens, right? Not a good thing to keep them running on. Multifocal PVCs, no, please don't keep them. A heart block that changes? No. Exercise-induced bundle branch block. In other words, you start to see RBB or LBB going on. Angina, that gets worse if they start to turn pale really quick. Their systolic goes over 250. Their diastolic goes over 100. It can be at 100. It just can't go over 100. Systolic pressure doesn't increase or falls with increases. Like we talked about that scenario where they went from 155 to, what did I say, 110? Right, if that blood pressure falls from incremental increase, then we know that that's a sign that cardiac output decreased, and that's a sign that heart's failing. They start to get lightheaded, like they're going to pass out. Of course, you start to see them turn blue. Stop it. Nausea, vomiting, of course, we don't want that on the treadmill. Cramping, of course, and then hyperventilation would all be bad signs. All right, so let's talk a little bit about Prasantin. So Prasantin is a drug that we can give that's a chemical stress test. So if a patient is unable physically to walk on a treadmill or do the bicycle, we can do the chemical version. This is for cardiac limitations. And so we'll give this to the patient. It makes the heart work out. So let's say they just had a knee surgery or a hip surgery, something like that, where they couldn't do it, then that could help, that we could still do the test without having to put them on the treadmill. Right, so this will exercise the heart, get the patient the same parameter. They can get very flush with this, and then the other thing that you need to be aware of this from a respiratory standpoint, and if I have experienced this myself, is Prasantin can also send someone into a pulmonary edema. Now, any of these can send someone into a pulmonary edema, like a cardiogenic pulmonary edema, right? So Prasantin, I've seen where patients will start to wheeze and they'll go into a bronchospasm as well. So Prasantin, got to be very careful. So make sure there's a nebulizer somewhere in the area that's available. It doesn't mean it needs to be open and ready to go. It just means it's got to be readily accessible. And then maybe if you have albuterol that's somewhat reasonably accessible as well, not a bad idea if you're doing Prasantin. In fact, I think our policy back in the day was to actually pull out the albuterol and keep the neb in its wrapper and stuff, but to have that with us whenever we did a Prasantin cardiac stress test. Things that should be present, make sure you got IV meds available, syringes, oxygen, of course, suction, emergency airway stuff. Hey, a defibrillator might come in handy. I'm just saying. And monitors. Usually we're watching them pretty closely, and you'll see the signs and symptoms before they get that bad, but you just want those available. And we've had a couple of codes in the cardiac stress area as well.